Hi everybody, and welcome to our module on mania. In psychiatry, mood disorders refer to disorders in which patients have an abnormal emotional state. And mood disorders occur along a spectrum. At one end are patients with sadness, we call this depression. At the other end of the scale are patients with mood disorders that have extreme happiness, and we call this mania. Just like patients who have depression can develop acute episodes where the depression worsens, patients who have mania develop what's known as manic episodes where their mood changes abruptly. Patients having a manic episode develop an abnormally elevated mood and energy level. These people are full of energy, they will talk fast with pressured speech, and they have a very decreased need for sleep. Importantly, however, they are not tired. This is different from insomnia. Patients with insomnia are tired but cannot sleep. Patients who are having a manic episode have no need for sleep and they feel energetic despite not sleeping. Sometimes they can go for days at a time without sleeping at all. Because these patients are full of energy, they will be pacing and fidgeting. This is called psychomotor agitation. And then in addition to their speech being pressured, they often demonstrate what's known as flight of ideas, where their speech changes from one topic to another very quickly in rapid succession. Patients having manic episodes become disinhibited and they act irresponsibly, so they will often waste money or gamble. They can sometimes wear no clothes out in public. These are all things that people do when they're disinhibited from a manic episode. They also display grandiosity, which is an increased self-esteem and confidence. Patients having a manic episode feel like they can do anything. I took care of a woman once having a manic episode who told me she was invincible to anything in the world. So the typical case of a patient having a manic episode is a patient whose mood changes to an elevated state. They stop sleeping but they aren't tired. They display altered behavior. And lastly, this disrupts their social functioning, and this is important. The disinhibition and grandiosity and the flight of ideas, all of these things get in the way of social functioning, and that distinguishes manic episodes from other things we'll talk about later where patients have more energy but are able to function. To meet criteria for a manic episode, you need to have at least 3 of these symptoms for 1 week most of the day, and the symptoms are remembered by the mnemonic DIG FAST. This stands for distractibility, irresponsibility, grandiosity, flight of ideas, agitation, less sleep, and talking too much or pressured speech. A hypomanic episode is similar to a manic episode, but it's less severe. And the major feature of hypomania is that there's usually little or no impairment in functioning. These patients have inflated self-esteem, but no delusions of grandeur. Their thoughts are more organized than patients who have mania. And these patients have more energy, but the excess energy tends to lead to productive activities, so they will clean the house or get work done during a hypomanic episode. In contrast, patients with mania are often unproductive and do things like spend money wastefully. And along those same lines, the risk-taking behavior among patients having hypomanic episodes is generally milder. To meet criteria for a hypomanic episode, symptoms have to last for at least 4 days, and there cannot be any psychotic symptoms. We'll talk about this later, but patients with severe mania disorders can develop psychosis, but by definition, if they have psychotic symptoms, those represent mania, not hypomania. So the typical case of a patient with a hypomanic episode is a patient whose mood changes to an elevated state, but they continue social functioning, they often get work accomplished, and it resolves over a few weeks of time. Bipolar disorder is referred to as manic depression, and the reason it gets its name is because patients with bipolar disorder have both mania and depression, meaning they exist at points in their life at both ends or both poles of the mood disorder spectrum, sometimes having mania and sometimes having depression. The initial presentation of bipolar disorder can be with a manic episode, a hypomanic episode, or with a depressive episode. When it presents with a depressive episode, it can appear to be major depressive disorder. However, if you treat this with antidepressants, that will cause the patient to develop mania, because that's what happens when you use antidepressants in patients with bipolar disorder. There are 2 subtypes of bipolar disorder, bipolar 1 and bipolar 2. Patients with bipolar 1 have manic episodes plus or minus depression plus or minus hypomania. If they have any element of their disease that involves manic episodes, then they have bipolar 1. Bipolar 2 does not include manic episodes. It includes only hypomania and depression. This is essentially a milder form of bipolar disorder in which there are no manic episodes. I mentioned this earlier, but patients who have mood disorders can develop psychotic features. Often these are hallucinations or delusions. These only occur in severe forms of mood disorders. They can occur in patients who have bipolar disorder and are having a severe manic episode, or in patients who are depressed and are having a severe depressive episode. They will always occur together with the mood symptoms if the patient has a mood disorder complicated by psychotic features. Patients who have psychosis without mood symptoms are having something called schizoaffective disorder, which I talk about in another video. Only when the psychotic features always occur in the setting of mood symptoms do we call it a mood disorder with psychotic features. Cyclothymic disorder is a disorder in which patients have mild mania symptoms and mild depressive symptoms that do not meet criteria for either hypomania or major depressive disorder. The symptoms have to come and go over at least 2 years, during which the patient will have ups and downs in terms of their manic and depressive symptoms. The mood disorder symptoms have to occur at least half of the time over those 2 years, and they can never be absent for more than 2 consecutive months. The normal course of bipolar disorder is a fluctuation in mood symptoms. Patients can develop episodes of mania, hypomania, and depression separated in time. In between episodes, they often have periods of euthymia, meaning they have a normal mood with no symptoms of mania or depression. Because the mood symptoms of bipolar disorder go up and down, the drugs used to treat bipolar disorder are called mood stabilizers. One of the most commonly used mood stabilizers is lithium, and we'll talk about this in detail in just a minute. Beyond this, the anti-epileptic drug valproic acid is often used, as well as 2 other anti-seizure drugs, lamotrigine and carbamazepine. Additionally, there are some antipsychotic drugs which are sometimes used, and electroconvulsive therapy is an option in severe cases. And then lastly, and I can't emphasize this enough, this is very high yield to know, antidepressants are not used in the treatment of bipolar disorder because they can cause mania. Even in patients with depressive symptoms, bipolar depression is always treated with mood stabilizers and not antidepressants. In patients who present with a first manic episode, meaning they have new onset acute mania, the usual treatment is lithium plus an antipsychotic drug. Sometimes valproic acid is used as an alternative instead of lithium. And there are a number of different antipsychotics that can be used. I've listed them here, and I talk about all these drugs in the video on antipsychotics. For the rest of this video, we're going to talk about lithium. Lithium is a very commonly used drug to treat bipolar disorder, and it's super high yield for your boards because it has lots of toxicities in different organ systems. Lithium is a chemical element. It's a cation. You can find it on the periodic table right above sodium, and it was the first medical therapy ever used for bipolar disorder in 1949. Its mechanism of action is poorly understood, but it has many toxicities and a narrow therapeutic index. So the serum level is monitored and the dose is titrated, and the therapeutic range for serum lithium level is 0.8 to 1.2 milliequivalents per liter. The elimination of lithium from the body is primarily through the kidneys, and much of it is resorbed in the proximal tubule, just like sodium, which, as I said, is a very similar chemical element. So because lithium is excreted in the urine, it's contraindicated in patients who have significant renal impairment, and patients often develop toxicity if they develop acute renal failure while they're taking lithium. The adverse effects of lithium really fall into 3 categories. There are acute effects that often occur when patients first start the drug, but then get better over time. These include tremor, which we'll talk about in a minute, and also nausea and diarrhea. Then there are the adverse effects that occur when patients have toxicity or poisoning and their lithium level becomes dangerously high. And then lastly, there are chronic effects that can occur in any patient who takes lithium for a long period of time, even if the level is always within the therapeutic range. When patients have lithium toxicity or lithium poisoning, it means that their lithium level has gotten outside and above the therapeutic range. The dominant clinical features are GI and neurologic. In terms of GI symptoms, patients have nausea, vomiting, and diarrhea. In terms of neurologic symptoms, patients have confusion, tremors, and can also develop seizures. The treatment is to stop the drug and consider dialysis. Dialysis is generally done if the level is greater than 5 or if the level is above 2.5 and the patient has severe symptoms. Let's talk about tremor in patients on lithium. Tremor often happens to patients taking lithium, usually when the drug is started or the dose is increased. It's usually a symmetric tremor that involves both extremities, and usually it's in the hands or the arms. And it usually gets better over time, so it's something you only see when you first start the drug or shortly after you increase the dose. Lithium tremor is the most common symptom of lithium toxicity, and so if a patient who is on lithium develops a new tremor and you have not recently increased the dose, you have to worry that that patient may be lithium toxic and you need to measure a lithium level. For patients who have a persistent tremor and need to keep taking lithium for bipolar disorder, you can treat them with the beta blocker propranolol, which will improve symptoms. So you can develop lithium toxicity if you take too much of the drug, either by accident or on purpose, but you can also develop lithium toxicity if certain other things occur. One of them is renal insufficiency, which I talked about earlier. Patients who develop volume depletion can develop acute renal failure, and this can lead to lithium toxicity. Lithium toxicity is also more likely in elderly patients because they have a lower GFR. Besides changes in renal function, you can also develop lithium toxicity if you take another drug that interacts with lithium metabolism, and let's talk about that now. There are a number of drugs that are associated with increased lithium levels. These drugs decrease the renal excretion of lithium. One of the biggest offenders is thiazide diuretics. This is a classic interaction that you definitely want to know about for your boards. Other drugs are NSAIDs and ACE inhibitors. These both disrupt kidney function and can lead to less lithium excretion. And then lastly, the antibiotic metronidazole and the antibiotic tetracycline have both been associated with higher lithium levels. Potassium-sparing diuretics will cause more lithium to go out in the urine, and they will decrease the lithium level. So a patient who takes one of these drugs can need more lithium therapy, or else they can develop symptoms of bipolar disorder. And then just for completeness, I'll mention loop diuretics. They have varying effects on lithium levels. They cause volume depletion, but they also modify the rate of lithium excretion. So now we've talked about adverse effects of lithium that can occur when you first start the drug. We've also talked about the clinical features of lithium toxicity. Let's round out this module by talking about the adverse long-term effects that can be seen in patients who take lithium for years at a time. Lithium can affect the thyroid gland, the parathyroid gland, and the kidneys, leading to nephrogenic DI, and we'll talk about all these things in a minute. Lithium can also affect the heart, and it has effects on the baby. If mothers who are pregnant take it, it can cause Epstein's anomaly, which we'll also talk about in this video. And then lastly, lithium classically causes a mild leukocytosis. There's a slight increase in the neutrophil count. This is common and a benign finding in patients on lithium. Lithium is a goitrogen, and this means it inhibits hormone release from the thyroid gland. And when this happens, the level of TSH released will go up and the thyroid gland will become enlarged. And therefore, lithium commonly causes a goiter, which is an enlarged thyroid. This occurs in about half of patients taking lithium. Also, because it inhibits thyroid hormone release, it can potentially cause hypothyroidism. Lithium causes a mild increase in parathyroid hormone levels, and this can cause mild hypercalcemia. This is usually asymptomatic, but is often seen on blood work of patients taking lithium. Lithium is famous for causing diabetes insipidus. It's referred to as chronic tubulointerstitial nephropathy, and what this means is that the kidney's ability to respond to ADH and concentrate the urine is blunted when patients are taking lithium, and therefore the tubules do not respond to ADH. As a result, lots of free water goes out in the urine, and the urine becomes dilute with a low urinary osmolarity. And what the patient will complain of is polyuria and polydipsia. They'll be losing free water in their urine all the time. This will make them have to go to the bathroom all the time, and that makes them thirsty, so they drink a lot. The serum sodium can be normal or increased. If they drink enough water to replace the water that's lost in the urine, they'll have a normal serum sodium. If they don't drink enough water, then they can develop hypernatremia. When patients develop diabetes insipidus and they're frustrated by urinating all the time, you can treat this by discontinuing lithium if possible, but often patients need to be on the drug for bipolar disorder. When that's the case, you can use amiloride, which is a potassium-sparing diuretic. It blunts the entry of lithium into renal cells, and it will improve the symptoms of diabetes insipidus, meaning patients will urinate less and will not be as thirsty. For your boards, you also want to remember that you can't give vasopressin. Vasopressin is given in central diabetes insipidus. It will lead to no response in patients who have nephrogenic diabetes insipidus from lithium. Vasopressin is the same thing as ADH, and patients with DI from lithium cannot respond to ADH. So if you give vasopressin, there's no change in urinary osmolarity, and that's because it's a nephrogenic form of DI. In the principal cells of the collecting duct, there is a sodium channel which pulls sodium from the urine and brings it inside the cell. This same channel also brings lithium inside the cell. And once lithium is inside the cell, it inhibits the ability of the cell to respond to ADH. And that's how you get diabetes insipidus on lithium. What amiloride does is it blocks this channel, and therefore lithium will not go inside the cells, and the cells will retain their ability to respond to ADH. Keep in mind, however, that by blocking this channel, amiloride causes lithium to stay in the urine and be excreted from the body, and therefore amiloride will lower the lithium level. And we already talked about this. Amiloride is a potassium-sparing diuretic, and all potassium-sparing diuretics cause the lithium level to fall for this same reason. In the heart, lithium can suppress sinus node activity, and this may cause sinus node dysfunction, so patients can potentially develop sinus bradycardia or rarely pauses or syncope. Maternal lithium refers to lithium administration in women who are pregnant. This is generally avoided because lithium is a teratogen. It completely equilibrates across the placenta so the baby is exposed, and the teratogenic effects primarily involve the heart and the fetus. The most common congenital heart defect in mothers who take lithium is Ebstein's anomaly. This is a rare congenital defect where the tricuspid valve is displaced downward in the right ventricle towards the apex of the right ventricle. When this happens, right ventricular failure can occur, and in addition, these patients develop lots of electrical abnormalities of the conduction system in the heart. I'll finish this video with this slide and talk about how to manage patients taking lithium. Prior to starting the drug, you usually get an EKG because you want to know the sinus rate and you want to make sure there are no other conduction abnormalities present. Serum chemistries are usually ordered because you want to know the kidney function and also the calcium level. A TSH is checked to screen for thyroid disease. In women, a pregnancy test is usually done, and then a urinalysis is usually obtained to look for protein in the urine as an early sign of kidney disease. After you start the drug, you check the lithium blood level at day 5 and then every 2 to 3 days, and then once the patient is in the therapeutic range, you usually check the lithium level every 6 to 12 months. In addition, the creatinine and thyroid function are also checked every 3 to 6 months because if patients develop renal problems or thyroid problems, you want to know about those right away. And that concludes our module on mania.